morning everyone. Myself Dr. Jayesh Prajapati, Professor and HOD UNMICRC Institute of Cardiology Research Center, Ahmedabad. So today I am going to discuss with you regarding the coronary perforation. We as an interventional cardiologist, we know that this is the complication most of the cardiologists they have faced or they have to face in their career because of newer things like imaging modality, and of course we are doing more and more complex cases. So this is the thing which can lead to the either a cardiac tamponade, cardiogenic shock or myocardial infarction, even death. And we know that perforation can lead to the tamponade, patient can die with either myocardial infarction or cardiogenic shock, and it was incidence is less than 0.5%. But with nowadays we are doing the routinely the CTO, we are using the so many devices, we are doing the complicated cases. So some of the CTO cases it can reach up to the 5% of the cases, and in hospital mortality is more than 5%. So patient can die after 1 or 2 days, and this is the complication which can occur immediately or sometime delayed. After 12 to 24 hours we can recognize it, and sometime it is very late also. And how it is defined? So it is defined as evidence of extravasation of contrast media or blood from the coronary artery during or following the PCI. So following the PCI in case of wire induced perforation, where the gradually it will collect, while during the PCI it can occur because of a balloon rupture or because of a stent related, and there are device related that I am going to discuss. Common classification what we are following is the Stephen-Ellis classification that most of us are following. So type 1 is extraluminal crater without the jet extravasation. Type 2 is the pericardial or myocardial blushing without jet extravasation. Type 3 is active jet extravasation and exit jet is more than 1 mm. Type 4 is leaking into another cardiovascular cavity. Either it can occur into the pericardium, sometimes it can occur into the RA, RV or coronary sinus or some of the chambers. And type 4 is a distal perforation, means wire induced perforation. These are the classification. So this is some of the diagrammatically I have explained how it can 1, 2, 3, and that is a thing. Among them type 3, 4 and 5 are the dangerous one. Other classification which are very simple, Foucaultomy and Kinney, they say simple. Type 1 is the staining without contra extravasation, means there is no leakage into the any chamber or into the cavity. Type 2 is epicardial staining with a visible jet of the contrast extravasation. So visible jet going into some cavity. Kinney is type 1 without contrast extravasation, and type 2 is contrast extravasation into pericardium, coronary sinus or the cardiac chamber. But most of us follow the Stephen-Ellis classification. Which are the etiologies? So commonest we see the perforation related to 2 or 3 things. So one is the guide wire induced. Nowadays we use a hydrocoated wire or the like Whisper MS, Pilot 50. So that hydrophilic wires they can perforate very easily. So that's why we have to keep watch over the eye. So while doing the PCI, whether there is leakage is there or not. Another is balloon dilatation, either a pre-dilatation or the post-dilatation. Nowadays we are treating the type B2 or C lesion, calcific lesion, we go very high pressure dilatation. So always we have to prepare the lesion very well rather than putting a stent and then aggressively post dilating. So IVUS and OCT or image guided PCI we can avoid this, but of course sometimes IVUS we overjudge the size of the balloon and we perforate. So always we have to never go beyond 1 to 1.1 to balloon to artery ratio, and whenever we go with a very high pressure we have to little undersize. And but because of nowadays we are using more of plaque modification device, sometimes we are using the cutting balloon, so it's a better thing to modify. But sometimes aggressive dilatation with cutting balloon can lead to the perforation. Even OPN-NC very high perforation noted when we go at more than 35 atmosphere. So always we have to downsize by 0.25 with OPN-NC balloon. So don't be over aggressive with balloon dilatation. Stent deployment, always is a dictum. We have to select the stent as a reference vessel diameter, as a distal reference we have to see. So we should take a stent not with a proximal reference, but we have to take with a distal reference diameter, so we can avoid the stent related perforation. And while post dilating, we have to be very careful to avoid the perforation. Another, because of other devices like rotablation. So rotablation also in a very tortuous lesion, we have to be careful, and while doing the rotablation, the guiding catheter should be hooked properly, should be aligned to avoid the perforation. Sometimes a burr can jump and can perforate. Atherectomy devices can also lead, very rarely IVL also, but laser also can lead to perforation. So we have to be very careful while we use the disease modifying devices, and that we have to keep in mind. So there are some of the risk factors which are modifiable one and non-modifiable one. If the patient having a blood pressure is very high, so always we have to bring down the blood pressure on 140, 160. Too much high blood pressure can lead to the perforation. The risk of dissection is also very high. Patient with polyvascular disease, CHA patient, lower body, thin and lean patient, they are also very high risk of perforation. Patient with CKD, they are also very high risk of perforation. Older aged patient, female gender, they have got a small vessel, calcific or some of the hormonal factors. So female patient, they are more prone for the perforation. So small vessel are more dangerous for perforation. And history of previous CABG, always when we treat the graft lesions, we have to see for the perforation, because the graft perforation there is no pericardium. So sometimes collection can occur to mediastinum or the pleura. So while treating with the grafts, we have to be very careful. Nowadays we are not using much GP2, but always when the patient is over-treated, like thrombolyzed patient, we use a GP2B or the ticagrelol. So when you use multiple antiplatelet or antithrombotic strategy, we have to be very careful. When the perforation occurs with such kind of situation, we have to treat them either with a fresh frozen plasma or the platelet rich. So use of GP2B3 inhibitors, we have to be very careful. Another important factor is the lesion related factors. So procedure related factor, as I have told that you have to be very careful, keep watch over the distal tip of the wire where it is, or movement of the wire, and of course we have to see the balloon to artery ratio. We have to apply our inner sense while using the imaging devices. Sometimes it is better not to be, sometimes the better is the enemy of the good, that we have to keep in mind. Angiotherapy related, as I have told, we are using GP2B3, anticoagulation, CKD patient, so that is important. Lesion related factor, calcific lesion, and another important type B2C lesion. Stent related factor, some of the stiff stent, balloon to artery ratio, that also we have to keep in mind. And balloon, while using the NC balloon, we should know the rapid, larger the balloon burst, that is most dangerous. So balloon related factor is also important. There are per site of the perforation also important while tackling the perforations. So whether the perforation to the main vessel, distal vessel, branch vessel or collateral perforation. Every perforation is different, we have to treat it accordingly. So this is kind of main vessel perforation, like RCA proximal or the mid, or LMCA perforation or proximal LAD perforation, distal wire perforation. So distal wire perforation, so distal wire perforation, there is also different. Collateral perforation, particularly epicardial collateral and myocardial collaterals. So this is, we have to be important. So epicardial perforation, the risk of tamponade is very high, while the myocardial means septal collateral, when it perforates, can lead to a septal hematoma. Sometimes it can lead to myocardial hematoma, can lead to a dry tamponade. Dry tamponade means there is no collection into the blood, collection into the pericardium or somewhere else, but it is related to hematoma and the cavity compression occurs, and sometimes it can lead to the hypotension. That we have to treat by giving the IV fluid support, and very rarely require surgery, and most of the time reversal of the anticoagulation that can relieve the dry tamponade requires some time. So dry tamponade also we have to keep in mind. So collateral perforation, sometimes we have to use the coil or the gel form, and we have to treat that kind of perforation. So of course the anatomy, we have to, very tortuous lesion, calcific lesion, angulated lesion, very narrow caliber arteries, and of course laser also we have to be careful. Oversized balloon and stent, we should not use it, and of course when we use a device, we have to be very careful, orbital and all kind of devices. So how we should manage it? So type 1 perforation, very easy to manage, most of they are stable, while once we have noticed, we have to not aggressively dilate and keep the balloon inflated for some time. Most of the cases doesn't require anything. Type 2 also, most of the cases, they are stable perforation, inflate the balloon at a low pressure, and usually most of the time it can most of it doesn't require cover stent or major intervention. Type 3 is most dangerous kind of perforation. So always once we notice the perforation, we see the hemodynamic instability or the stability, keep the balloon inflated either at the site of the lesion or proximal to site with a nominal pressure around 6 to 8 atmosphere is enough to occlude the flow, and we have to see there is flow is going on or not. We can keep it a balloon inflated around 20 to 30 minutes. In between, at this 5 to 10 minute interval, we have to deflate the balloon sometime to allow the flow to go. Sometimes patient doesn't tolerate the ischemia, then we can keep a partially inflated balloon to reduce the flow. That also suffices till we can think something else. So always once after post dilator, always check with the shoot there is perforation, particularly when the balloon rupture or something like that. So keep the balloon inflated and think for the other thing what is to be done, whether you have got a cover stand is available or not, or some other technique we want to try, you want to tap meanwhile. So always keep the balloon inflated at nominal patient. Nowadays there are some of the perfusion balloons are available like ringer balloon where they allow the perfusion, and most of the time this technique around 80% of the time keeping the balloon inflated works, but we have to see for the thrombosis. And regarding the reversal of the heparin with a protamine, we have to check the ACT, but don't reverse too much because it can lead to the proximal thrombosis and patient can die of ischemia also because of thrombus. So, and in between you have to check whether the perforation is sealed or there is a free flow. And if there is hemodynamical instability, give the IV fluid first, make the resuscitation, put a pigtail inside the pericardial cavity, aspirate it, do a auto transfusion. So that is a remedy. And suppose there is a rupture into the cavity. Most of the time cavity rupture we can observe it, and most of the time either you suppose it's a large perforation into cavity, keep the balloon inflated, and most of the time it seals, but we have to see the shunt later on by CT angiography. So into the cavity doesn't require much, but hematoma we have to be very, dry tamponade we have to be very careful. But if it is inside the pericardium, always we have to think for something. If it doesn't seal off with this kind of things, we have to use a covered stent. So covered stent is most important thing that we have to keep in mind, and put a covered stent. How to put a covered stent, I'm going to discuss in a next couple of slides after this one. So that is regarding type 4. Type 5 usually it is late recognized, and gradually there is collection and is wire related perforation, and once we notice on the table, we have to inflate the balloon distally and we have to flow. Most of the cases flow stops. So there is various techniques to seal the distal perforation that I am going to discuss. So type 4 perforation, we can close it by so many means I am going to discuss. So which are the devices? So cover stent for the proximal or the mid perforation, we can use a cover stent, either is a papyrus or this one another is a Abbott available is a stent. Graft master is bulky. Sometimes it is very difficult to go with a 6 French guiding catheter. It is better to use a 7 French guiding catheter when you use a ping pong technique that I am going to discuss. So cover stent issue with the graft master is very difficult to tackle, but the biotronic papyrus is very good to tackle. So that type of you at the site of perforation, you can deliver the cover stent by two means: single guide, 2 wire technique, or a double guide or ping pong technique that I am going to discuss. If there is a distal perforation, we can use a coils, micro coils for the distal coronary coils for the distal perforation. We can inject a micro spares or the emboli like gel form, autologous blood, same clot. You inject it with some of the contrast media mixing, so you can visualize it, or you can use subcutaneous fat particle, so that can also be injected with a micro catheter. Go with a micro catheter distally. That you can use either two way. Keep that balloon inflated to the vessel, take a second guide, put a second wire, put a micro catheter, and you can deflate the balloon and you can inject it. So that is a simple way. So if it is a 7 French guide, you can do with a single guide technique, put a second wire through the same guide, put a micro catheter, inject particles and deflate the balloon, second balloon. So either you can use a that I have told, autologous blood, fat particles, or put a coil, micro coils, or you can use some of the gel form or something like that. Or sometimes some people have did a dissection into distal LAD or something diagonal, or you can isolate that diagonal with either a covered stent also. That way you can seal off the side branch perforation or the distal perforation. Very rarely, while even putting a covered stent, while using a covered stent, you have to be very careful. You should to specify the certain area where the perforation is. So sometimes you put a covered stent till there is a leakage, so you have to post dilate it and make it a proper, because these are the optimization most important in covered stent. So sometimes you have to put a second covered stent also. So or post dilatation is most important while using the covered stent. You have to seal it off properly while using the covered stent. Sometimes with a very diffuse perforation and patient requires surgery also. So which are the novel approaches? As most of the things I have discussed, while the CTO perforation very dangerous, collateral perforation, either you can put as I have told, you can put a gel form isolate to collateral, or put a covered stent, and that way you can manage the collateral perforation also. So catheter technique to deliver a covered stent. So either you can put a two guide, suppose you are doing to the right radial, take another access to the femoral, keep suppose you are doing the radial artery, the balloon need a perforation, keep the balloon inflated there, and from the another site like femoral, you take another guide and engage with that guide. While that, remove the disengage the original guide, put a second guide and pass a wire and put a covered stent, and that temporarily deflate that balloon and pass the covered stent, inflate it. So either double guide catheter technique or single guide. Suppose you have a large guide, you can put a second wire side by side, put a micro catheter, or put another stent like papyrus kind of stent where the 7 French, you can do both the things. So single guide or the double guide technique, that we have to be careful. This is a diagrammatically thing that I have told. Keep the balloon inflated. You can pass a second wire. You can put a guiding catheter, deflate, or you can put a guide catheter, wire, keep the balloon deflated, just withdraw that balloon and inflate that stent. You can seal off the perforation and do the things. So always I know that 7 French guiding is better whenever the perforation. 6 French papyrus can easily accommodate, but the larger stent, more than 3.5 mm stent, very difficult by 6 French guide. So these are some of the micro coils available for the perforation, and you can put through the micro catheter, and there is a plunger is there. Detachable coils are also available, or you can use a simple your PTCA wire and you can push the coils. So this is how you can seal off the distal, like you keep a balloon inflated, pass a micro catheter side by side, put a gel form or embolize and close the distal branch. So that is important thing. So this is how you can seal off the perforation. You put a pigtail, and or you can do a autologous same auto transfusion to the another site, and meanwhile you seal the perforation. So once you have sealed the perforation, observe the hemodynamics, repeat the echo after 4 hours and observe it, and reverse the heparin. Once the procedure is done, reverse it, see the ACT, and if there is no collection within less than 50 cc collection after 12 hours, then withdraw everything. So always put a pigtail, never keep only sheath, because sometimes the sheath can traumatize and another perforation can occur. So keep the pigtail inside for 24 hours till some oozing or something seals off. So that is the best strategy. So which is the journal, summarize this part, and I'll discuss some of the cases. So always inflate the balloon to occlude either a proximal or at the site of vessel. Sometimes the collaterals are filling up a distal vessel, then it is very, very difficult. So you have to seal off the perforation, that collateral also. So in that cases, you have to put a balloon at the site of perforation. Always give the IV fluid. Once the tamponade occurs, don't try to give the inotrope. Give always the fluid. Pericardial centers, if required, call for the surgeon, call the anesthetist, because the patient can arrest any time. And keep the cover stent. Always keep the cover stent into your lab. Keep the prolonged balloon inflation and manage the perforation accordingly, either by cover stent or the embolization of the devices. This is one example. So where I want to show. So this is one example. So see that. So this is one example. This is a type 2 perforation, and suddenly it has given away, and it frankly to the pericardium. So there is hematoma, ruptured. So this is how it ruptured. So see, this is concealed hematoma. Suddenly it ruptured. So then what I did, I tried to put a covered stent. I keep the balloon inflated. I tried to put a covered stent, but doesn't went in. So that was the thing. Meanwhile, I did a pericardiocentesis, doesn't went very well. Then what I did a repeated inflations, and then see, it has sealed off. See, this is covered stent not went, repeated inflations and repeated inflations. So covered stent not went, and this is how. Then gradually kept balloon in for 2 hours. There was a oozing for 48 to 72. I kept the pigtail, but gradually patient recover. I was able to discharge after 7 days. So sometime the repeated balloon inflation, I put a bare metal stent inside. So sometime the second stent can also seal off that thing. So multiple stent can sometimes seal off. So this is the post stent. In post stent, see that post stent. See, there was a perforation. See, after post dilatation, there was a perforation and there was a tamponade. So that double guide I used. So second guide I used, did a ping pong technique, and I have delivered the stent and I have stopped the perforation. So see, then I have stopped the perforation, putting a second stent. So this is a ping pong technique. So this is one thing. This is simple. This type 1 perforation, only one crater. This is a female patient. Only crater outside, type 2 perforation I can say, but there is no leakage. So what I did, just gradually I observe. So I did a repeated inflation and see it has sealed off. Nothing I did, observe the patient, no pericardial collection, and it has stopped. So repeated inflation and this has stopped. So, and another, this is wire induced perforation, type 4 perforation. So this was a CTO we were trying. See, this was kind of CTO. Where I went, we don't know. So it was in a diagonal, and this is Tazuna. We did we went and come back. Daughtering we did, and we noticed a perforation. And patient became hemodynamically unstable. So we have to put a pigtail, but luckily wire was inside, and there was not a major vessel. It was a CTO, and it was a proximal perforation. Collateral was filling up a distal perforation. We went to the diagonal. So perforation is proximal to the CTO, so very easy for us. So what we did, put a microcatheter over that wire. We have got a vascular interventionalist our lab. They have got a PVA particle, cheap things. So we have microcatheter we have put and pushed the PVA particle inside, and we were able to stop that thing. So see, so this is the PVA particles, and we were able to stop that thing. So one important thing is to prevent it. So prevention is better. Keep always ACT to the optimum. Measure the ACT. 2B3, don't use haphazardly, because nowadays Brilinta is enough or ticagrelor is enough. Don't give too many antiplatelet or antithrombotic drugs. UFS is always don't rely on Claxon or something like that. Give the heparin only. So that is bivalirudin is complicated. So always give the unfractionated heparin. Always use a multiple views, confirm that wire position. Dual injection sometimes helpful while doing the CTO. With the CTO perforation, wire can perforate. So take a dual injection. See whether in a true lumen or a false lumen. Delayed watch. Whenever they leaving the during the balloon mitral valvotomy, we always watch to the apex. Same thing. Always keep watch over your eye. Watch over the tip of the wire. So always keep watch over the apex. Start with a workhorse wire. Always don't use in all the cases whisper or hydrophilic wire for each and every case. You should use a BMW or the Sion Blue kind of wires. IVAS always is a better thing to judge the size of vessel and work accordingly. But don't overestimate the vessel size also. Always apply your inner sense while using the post dilatation or the pre-dilatation. Confine the wire to the true lumen while see the wire within true lumen while using the CTO. So that's why the dual injection is important. And don't dilate in side branch or collaterals. So side branches, whenever doing the CTO, retrograde CTO, we have to be very careful. So to summarize, to conclude today's discussion, perforation is rare but it's inevitable. It can occur at any time in complex PCI, especially during the CTO interventions. Rapid assessment and knowing all available treatment modalities necessary. So earlier recognition is important. Late recognition, sometimes middle of the night at 4 a.m. comes with ICU call that patient is arrested. You know there is a tamponade, you have no time. So always keep, before shifting the patient, sometime when you doubt, you check with an echo whether the collection is there or not. And always record the heart apex or see the heart apex. Always respect the anatomy and always prepare for the worst. So always respect the vessel that our teacher Dr. Samuel Matthew used to tell. Always respect the coronaries. So don't over dilate thinking that nothing will happen to the artery. They can rupture at any time, can create a havoc. Particularly wherever you are using the disease modifying devices like rotablation, cutting balloon, OPNNC, high pressure balloon, always be careful. Laser kind of devices also we should be careful. So prepare for the worst and always keep the all kind of devices like perfusion balloon or covered stent or microcoils or gel form particles. Make everything handy and always ask for a help. Never think that you are the boss. Always ask for the help. So anesthetic surgeons or always whenever there is emergency, always call your colleague inside the lab to tackle the things and you can give always a better outcome to your patients. Thank you. Thank you so much.